Good morning, everyone, and truly it's a pleasure to be with you here. This is a very nice place to hold a conference. It has many great things, hikes and other things, and they have a good morning mimosa but don't worry, I had some coffee after the mimosa, so we'll find out if that will drive my talks down. So it's good to be with you. So we'll start. My objectives is to discuss with you the role of DOAC, the direct oral anticoagulant. So they're not called NOACs anymore. They're not novel anticoagulant. They are direct oral anticoagulant in patients with valvular heart disease and atrial fibrillation. So what I'm not going to discuss today, although I'm happy to answer some questions, is how do we bridge these patients around the time that they need to stop their anticoagulant. And I'm also not going to discuss valvular heart disease in the absence of atrial fibrillation. So these are other scenarios that can be a subject of debate at another time, but today we'll focus on valvular heart disease and atrial fibrillation. And my goal is to really break down valvular heart disease and show you where DOAC have been proven to be effective and safe, and where DOACs are not yet studied enough. So that is my objective from today. So, the European Medical Agency and the FDA kind of both agree on the definition of valvular heart disease, which is the absence of moderate to severe mitral stenosis, mechanical heart valve, or bioprosthetic valve. Those who don't agree with this definition are clinical trials. So kind of every clinical trial conducted for the direct oral anticoagulant adopted slightly different definition for valvular heart disease. And valvular heart disease is not an irrelevant problem. There is about 100 million humans on the face of the earth that has some sort of a valve problem. And some of them require valve replacement. And there's an increase debate on which valves are better, but certainly a lot of us believe that bioprosthetics are probably better than the mechanical valve. We don't want to insert metals unless we have to, unless the patient is very young, and that kind of so I'm going to break valvular heart disease just to kind of make it easy, and that's how I approach it in my practice. And some of you may disagree with this breakdown, but this is kind of to simplify it for me. I break it down into native valves, those that have some sort of an aortic valve disease or mitral regurgitation, mild mitral stenosis, tricuspid regurgitation. The second group is kind of the one that's becoming more popular, those with bioprosthetic